Good afternoon, everyone, and welcome to the Melanoma Research Foundation Ask the Expert. Today is our third session, and I'm so pleased to be joining you. My name is Kylie Lapira. I'm the CEO of the MRF based here in Washington, D.C., and our mission is quite simple: to eradicate melanoma by funding research, educating the community, and advocating for their needs. So I'm so pleased to be with you today to talk about this important session on immunotherapy. As many of you know, education is absolutely critical for patients making informed decisions about their care. So we're so thrilled to partner with OncoSec on this Ask the Expert series, which is touching on topics to educate and empower our community. For those of you who don't know, OncoSec is a late-stage biotechnology company developing immunotherapy cancer treatments using their plasmid DNA delivery platform. Through this technology, they're working to deliver safe and effective cancer treatments that can provide long-term benefits for patients. Their primary technology, TAVO, is a potential treatment for multiple cancer indications, either as a monotherapy or in combination with leading checkpoint inhibitors, in particular, meeting the great unmet need in anti-PD-1 non-responders. So today, we're going to talk about our third session, which again is immunotherapy. If you've missed our previous two sessions, those are available on the MRF's Facebook page, where we touched on clinical trials and the role of care partners, two really, really important topics. And again, you can view those on the MRF's Facebook page. So today, for immunotherapy, a very hot topic for melanoma patients is a type of whole body therapy used for treating metastatic melanoma or melanoma that has a very high risk for recurrence. Immunotherapy treats the whole body by attempting to activate that person's immune system so that it will destroy any melanoma cells in the body. Immunotherapy is prescribed and administered by a medical oncologist in a variety of ways, most commonly by using biologic agents that stimulate the immune system. Other mechanisms are currently under investigation in clinical trials. But today, we're going to learn a little bit more about what immunotherapy is, a little bit about where it's come, what patients are experiencing with immunotherapy, and what lies ahead. So we really encourage people to ask questions. Please use the comment section in our Facebook live stream, and we'll get to those at the end of the session. But again, we just want to make sure that everybody knows that the information today that's being presented is for educational purposes, and any treatment questions that you have should be directed to your healthcare provider. We encourage people to visit melanoma.org, the MRF's website, so you can utilize our free resources like our clinical trial finder or treatment center finder. We also have a free Ask a Nurse service where patients can connect and ask questions as well. So again, please use the comment section. Again, any personal medical questions we cannot answer, they have to be directed to your healthcare provider, but we're happy to answer any other questions. So with that, I would like to introduce our speakers for today. First, I'd like to introduce Dr. Michael Atkins, who is the Deputy Director of the Georgetown Lombardi Comprehensive Cancer Center right here in Washington, D.C. He is the Professor of Oncology and Medicine at Georgetown University School of Medicine. And Dr. Atkins is also the co-chair of our Scientific Advisory Committee here at the MRF, as well as the co-chair of our MRF Breakthrough Consortium. So with that, Dr. Atkins, I'll let you say a few words about yourself.
Yes, hello, Kylie, and good afternoon. It's good to be part of this interesting discussion. And I just want to say that this is an area I feel very strongly about, having worked for over 3 decades in developing immune therapies for cancer, particularly focused on melanoma. And I'm happy to be here to share some of my knowledge and hopefully address some of your questions.
Thank you so much, Dr. Atkins. Now I'd like to introduce Doug Brodman. Doug is a stage 4 melanoma survivor and vice chairman of the MRF board. Doug?
Thanks, Kylie, and good afternoon, everyone. So I am a stage 4 survivor. I was diagnosed in late 2013 by my dermatologist and endured a 2-year journey to land at a very successful no evidence of disease. So immunotherapy was my ultimate solution. Since 2015, I returned to work as a corporate executive for a year, and then I began my involvement with the MRF and joined the MRF board in 2018, and very happy to be here and help find more solutions. Thanks, Kylie.
Thank you, Doug. And now I'm going to turn it over to Suzanne Milne. Suzanne is also a stage 4 melanoma survivor and wonderful advocate of the Melanoma Research Foundation, who joined us at our last public event here in DC at our Hill Day and Advocacy Summit. Suzanne?
Right, so good afternoon, everyone. I live in New York City. I've been living here for 17 years, and as Kylie said, I'm a melanoma survivor. I've been a stage 4 melanoma since for the last 6 years and 9 months. And for the last 6 years, I've been heavily involved with the MRF, and it's been a really great experience in terms of meeting other people with the same disease, with meeting with caregivers, and particularly also meeting people from the medical society and better understanding that, as well as you mentioned, the Hill Day. Going to Hill Day is such a big thing because you're part of possibly changing policies and making sure that money is funded for melanoma research. So that's a great thing to be part of the MRF.
Thank you, Suzanne. And lastly, I want to introduce Nadia Jabri. She is a melanoma advocate. She also joined us at our Hill Day this past March. She was the caregiver to her mother, who sadly passed away this year from melanoma. Nadia, would you like to share a few words?
Yes, I'm Nadia Jabri, and I took care of and advocated for my mother, Ursula. She was diagnosed in 2014 at stage 2B at that point. And yes, she passed away just in August, but I'm very happy to be here because I really want to share our experiences and try to help our community. That's something that was very important to her, and she was very excited when I managed to go to Hill Day. So she was excited for that, and I'd like to, honor her legacy. She had several experiences with immunotherapies. She did immunotherapy about 5 different times in 4 different hospitals. So we had a really broad experience. Unfortunately, she was not a responder at all to immunotherapy. She progressed each time. However, it was recommended that she do immunotherapy in different situations to potentially curb growth when she had to stop targeted therapy. So even though she wasn't responding, it was still recommended to do it in certain contexts, or when she had to wash out before doing radiation or getting ready for a clinical trial. So that was kind of an interesting potential for immunotherapy despite not responding. She was also not pre-tested for PD-1 or otherwise to predict benefit because we were told it doesn't really sort of matter at this point. If she doesn't express PD-1, it may still work. So we're kind of not there yet with pre-testing. So I'm very curious to know what other people's experiences are with regards to that. Thank you. Thank you for having me.
Thank you, Nadia. So now let's talk a little bit about what immunotherapy is and how it's evolved over the years. And we're going to start off with the medical perspective from Dr. Atkins. So Dr. Atkins, can you share a little bit about what immunotherapy is and how it works in the body, and when a patient should have that discussion with their doctor? How early on does that discussion take place?
Sure. So immunotherapy really has produced a revolution in the way we treat not just melanoma, but a number of different cancers, over 20. And progress in immune therapy is not just changing the way we care for patients with many cancers, but the very way we even think about cancer. So cancers are increasingly being viewed as abnormal cells that have figured out how to escape the body's immune response. From this perspective, identifying the optimal treatment strategy is less about what is driving a particular cancer and more about identifying the mechanisms by which a tumor has escaped the immune response and then trying to disable them. And just as a background to get some better sense of this, all cancers have mutations in their DNA. And melanoma is no exception. Melanoma is probably one of the cancers that has the largest number of mutations because of sun damage. And some of these, like the BRAF mutation that people have heard about that occurs in about 40 to 50% of patients with melanomas, enable cancer cells to escape physiologic regulatory mechanisms that keep cell growth in check. And these are considered driver mutations, and that's what targeted therapies target. However, most mutations in tumors have no function whatsoever. They're just there for the ride, and therefore we call them passenger mutations. And these mutations can lead to abnormal proteins that get expressed on the surface of the cell. And the immune system can then recognize these mutations as foreign, these mutated proteins as foreign, and attack these mutation-bearing cells in the same way it would attack a virus and eliminate it. And therefore, in order for a cancer to survive, they need to figure out how to evade the immune response. And research over the past couple of decades has revealed that many cancers do this by a common mechanism. They express proteins that we call immune checkpoints, such as PD-L1, which we've learned can, when it binds to PD-1 on an activated immune system, disable that immune response. And if we can give an antibody that blocks the binding between PD-L1 and PD-1, we can restore that immune response against those foreign proteins in the tumor. And this activated immune system, once activated, can attack many different mutated targets simultaneously, essentially machine gunning the tumor rather than just blocking one pathway. And this immune response can expand and evolve over time, leading to the elimination of the last tumor cell, producing cures, which is a unique property of immunotherapy that's not shared by therapies that directly target the tumor cells. And because the immune system is reactivated preferentially in the tumor microenvironment by these anti-PD-1 agents, these agents are usually well tolerated, allowing combinations of immunomodulatory drugs to be developed. And these agents can be therefore provided earlier in the course of treatment, increasing their curative potential. And therefore, if you have melanoma and it's beyond stage 1 and it's been resected, you should be asking your dermatologist about whether you should be seeing a medical oncologist, and then you should be asking the medical oncologist about whether immune therapy is right for you.
So that's very early on.
Yes.
Then, okay, great. So let's move over to Doug. So Doug, you experienced immunotherapy. Can you tell us a little bit about sort of your experience and what questions you had for your oncology team when it was presented to you?
Sure, Kylie. Yeah, as Dr. Atkins just mentioned, my experience is about 5 years old now, so the journey was a little longer to get to immunotherapy. But briefly, my journey came from discovery by my dermatologist of a mole in my scalp, and then having it diagnosed and moved across to my oncological team as a spindle cell melanoma. So it was a single melanoma in my body. So surgery was selected as my best option to remove the tumor in my scalp. And the surgery was successful. We also did some exploratory lymph node dissection, and it showed one lymph node was infected with the melanoma. So the course of action at that point in time was, let's do a course of radiation for preventative reasons around the site. And during the last few days of a month-long treatment, another tumor emerged near the original site. And PET scans followed, and that revealed that I was now stage 4. And the melanoma had actually spread to my liver and lungs. And this is all within about 30 to 45 days. So having run through several courses of treatment over 3 months, the options were somewhat limited, and the decision to move on to what was at that point a research trial for stage 4 patients incorporating immunotherapy was a pretty obvious solution. And that therapy had to do with a sequential dose of immunotherapy. So it was a approved drug of Yervoy and a new drug called nivolumab, which is today is Opdivo. So I had a lot of questions because it was not a single therapy, it was a double, so why 2 drugs given sequentially? And the early combination therapy, which Dr. Atkins could probably speak more about, was starting to show promise at that point in time. And it seemed with the aggressive nature of my cancer, that was a good way to go. Second question was, what are some of the side effects? Because I was venturing into unknown territory. So some of the side effects were known from single immunotherapy treatment, but some would be found out in the trial because I was dealing with a sequential trial. And then the big question that I had was, what if this doesn't work? And the response I got from the doctors at that time just exuded confidence in that with the advancements being made so rapidly, other options would come on the table if this didn't work. So building confidence in me and my decision was very important. So I felt comfortable with the approach. The options were somewhat limited to what I could do, but the therapies were showing promise. So we moved ahead with it. And I was obviously satisfied with the results.
Great, thank you, Doug. And as you mentioned, that was 5 years ago. So, and to Dr. Atkins' point, things are constantly evolving, as you know, which I'm sure you've seen quite a bit over the last 5 years. Let's pivot over to Suzanne now. So Suzanne, you also had immunotherapy, and as you mentioned, your journey has been going on now for 6 years. So you have experienced many different types of treatments. Could you talk a little bit about, sort of your experience and your treatment journey, and, when one treatment didn't work, what was that conversation like with your physician to try something new and different?
Yeah, so I'm what's called a BRAF melanoma patient. So I've been early on when I was diagnosed as a stage 4, we tested the tumor that was taken out of my lung, and that was a BRAF tumor. And a little bit like Doug, things kind of spiraled and went very quickly. Suddenly it had spread to my liver, and also very quickly spread to my brain. So within 9 months, I had gone through a tumor resection, started BRAF inhibitors, and had a huge tumor taken out of my brain. So that was kind of a slightly rough year. I was also struggling a bit on the BRAF inhibitors. I reacted very strongly with lots of skin issues, mainly on my legs, lots of fevers overnight, not being able to eat very well. So we worked with some of the medications, the BRAF inhibitors, tried different types of medications for me to take, and continued in that way. And I would say for the first couple of years, it was mainly the BRAF inhibitors and doing a number of operations and surgeries. At one point, we did start looking into immunotherapy, and I've actually tried a couple of different things in terms of whether they are injections, similar as Doug was saying, with 2 different types. I was also part of a clinical trial, which was a T-cell trial that was happening here where I'm living, and that was part of taking a tumor that was taken out of my stomach, that was tested and was sent out to enhance those T cells. They were then brought back to me, where after I'd had a week of chemo to flatten my immune system, then these T cells were brought back and put into my system for a week. And then I was sent out into the world to hopefully that this would work for me. Unfortunately, this clinical trial did not work for me. I continued to have tumors growing again in my lungs, in my breast, a couple of different places. And so I actually went back to the BRAF inhibitors again, because it seems that the immunotherapy, unfortunately, isn't really working for me.
And is your doctor sort of discussing what that next potential treatment option could be? Is that always in discussion?
It's always in discussion, and we've actually recently put me back a little bit on some immunotherapy. I was going through a period where the BRAF inhibitors weren't really, they had been working really, really great. And then I started to, they have small tumors grow again. So it was kind of like a restart of my rebooting the computer, but rebooting my system, where I had some chemo, as well as we tried a couple of different immunotherapies, just also injections, going through that on a kind of every 3 weeks. And currently I'm then back on my double dosage of 2 different medications for the BRAF inhibitor medication. So it's always, my doctor is always very clear about what the next steps are, why we're doing this. And I'm still hoping that this year will be my first year of going through not having a single surgery, which would be very nice.
We hope that as well. Wonderful. Well, thank you, Suzanne. I'm going to pivot over to Nadia now. Nadia, you know, as a caregiver and certainly somebody who's advocating, you know, for your mother during all this, when immunotherapy was brought up, did you know much about it? Is it something that you'd heard about before, or was it something that you really had to educate yourself on?
So she was diagnosed in 2014, like I mentioned, and at 2B. And so after her wide local excision, she was disease-free NED for about 17 months. And then a PET scan showed that she had some local node involvement in her groin area. So they took out those 2 nodes. And at that point, her oncologist, actually it was October 2015. So I believe this was the same month that the FDA approved adjuvant ipilimumab for stage 3C, I think, or 3B. So correct me if I'm wrong, 3B or 3C, whichever one is the one that she was at just in that moment. So the oncologist that she had in California at the time suggested it, recommended it right away. So I hadn't even heard of immunotherapy at that point. I got involved with her care and advocating for her right away when she was diagnosed, but was more kind of involved in, you know, what type of surgery she was going to have, because it was very invasive, as often they are, as well as what kind of lymph node dissection she may or may not have. I didn't want her to ever have a radical dissection, and also trying to get her proteomic testing at that point, which was really far off and nobody wanted to do it. So I was starting my education at that point. It took me a long time to find a community, as you know, a long time to find MRF or even other patients. So I think immunotherapy didn't even pop into my head right in the beginning. So it was the oncologist who brought it up to do it adjuvantly. Although he said, it's much better than chemotherapy, you'll only have some fatigue. So this was ipilimumab at 10 milligrams. So when I started my research on ipi at that point, one of the main side effects was death. So I thought, this sounds serious. So we reached back out to him and said, I think we need to have a more extensive conversation so that we can be better prepared. My mother was 73 at the time. So age really matters. Comorbidities really matter. She had high blood pressure, AFib, things like that. And, just to be better prepared. So I had to push back on that to really understand that. And I'm not sure how standard this was, but she received the infusions with Benadryl. I don't know if everybody was doing that at that time, if they're still doing it now. I know in the combination of Ipi and Nivo, Benadryl is sometimes given, sometimes not given. It depends on where you're getting it. But she got it without us having to ask, because I wouldn't have had a clue at that point. And she fared actually pretty well. She had a bit of hepatitis that was a bit of hepatitis that was controlled by steroids. So she fared okay about that. And then as we went on and did, more and more immunotherapy as we went along, I was more informed at that point. And, my mother got to know her own self, and I got to know her as she was going through things, so that we could really kind of get a hang of it. So so to speak. But there was still a lot to learn.
Thank you, Nadia. So let's go back to Dr. Atkins, because what we've seen here is that there's certainly been this evolution, even over the last 5 years, in immunotherapy and treatment options, and more things coming down the pike that are either available and FDA approved or in clinical trials. So Dr. Atkins, let's talk a little bit about, the advancements that have been made in immunotherapy treatments and kind of where we're going at this point, and what excites you as an oncologist who's treating somebody who's diagnosed today.
Sure, delighted. So in 2011, 2012, the median survival for someone with stage 4 melanoma was 6 to 9 months, and less than 10% of patients lived 2 years. With the BRAF inhibitor drugs and combination checkpoint inhibitor immune therapy, like Doug mentioned with ipilimumab and nivolumab, there is no longer a median survival, which means 50 to 70% of patients are anticipated to be cured with therapy at the academic medical centers. And so that's a remarkable change. And so we have a lot of stage 4 melanoma patients who are alive now. And as a matter of fact, it's becoming more the rule than the exception. But there's still 30 to 50% of patients with stage 4 melanoma who, despite all these treatments, are destined to die of their disease. And so there's room for new and improved treatments. And a number of those are immunotherapy based. And the type of things that we're doing to try to raise the plateau, which is already pretty high, higher, are moving immune therapies to the adjuvant setting, not just ipilimumab, as was mentioned by Nadia that her mother received, but giving pembrolizumab and nivolumab in the adjuvant setting. We're also starting to give treatment ahead of surgery, what we call neoadjuvant therapy, which is producing what appears to be better results than doing surgery followed by adjuvant therapy, because there's more immune cells around the tumor at that point, presumably to not only reduce the tumor that you're going to resect in size, but also potentially attack the tumors in other parts of the body that you can't see. In addition, by taking that approach, you can also identify early whether the treatment is working for an individual patient and modify the treatment if it's not, reduce the amount of therapy that patients are receiving if it works, and also it's a way of developing combinations of novel immunotherapies and seeing early on whether those treatments are actually more effective than the standard of care. We're developing ways to reactivate the immune system in patients whose tumors have not responded to checkpoint inhibitor immune therapy by either giving injections into the tumors that re-inflame the tumor microenvironment, or by hitting other factors in the tumor microenvironment that may be suppressing the immune response. We're developing other ways when there's inadequate immune response of eliminating all the immunosuppressive factors with lymphodepleting chemotherapy, and then taking out the cells from the tumor and growing them up and giving them back in what we call adoptive cellular therapy, or TIL therapy, that I believe Suzanne said that she received. And that approach is actually will likely be FDA approved soon. And we're also identifying ways of trying to identify how a particular tumor is escaping the immune response, so that we can develop biomarkers to tell which combination regimen would be particularly useful for a particular tumor, and also biomarkers to identify early when the toxicities of immune therapy are happening, so that we can intervene earlier and prevent the real symptoms or prolonged toxicities from these therapies.
Thank you, Dr. Atkins. So let's talk a little bit about side effects, because a lot of times when you mention cancer treatment, people kind of have this image of, losing your hair and really looking like you've had a chemotherapy. With immunotherapy, it's a different type of therapy. And what can a patient expect in terms of side effects from an immunotherapy? Is there a common sort of list, or does it differ by each person?
Sure. So the most common immunotherapies are the checkpoint inhibitors. And as I mentioned before, these treatments are designed to take the brakes off the immune system. And one of those brakes is primarily just within the tumor microenvironment. That's the PD-L1, PD-1 pathway. But another brake is a physiologic brake that's a normal shutoff valve that keeps the immune system from getting too overreactive and starting to attack normal cells. And that's the CTLA-4 brake that ipilimumab hits. And so when you give immune therapies, you're hoping to activate the body's immune system, and your hope is that that activated immune system will recognize the tumor as more foreign than the host. But in some patients with some treatments, either they're predisposed to have their immune system recognize normal cells. They are predisposed to what we call autoimmunity, and therefore you can't activate the immune system to recognize the tumor without recognizing this self. Or we activate the immune system, and it starts not only recognizing and hopefully eliminating the tumor, but also recognizing normal cells. And the typical, so then you get what we call immune-related adverse events, which are all itises, and they can occur in a variety of different organs. The most common is the skin, but you can also see in the colon, which is called colitis, the liver, which is called hepatitis, the thyroid gland, which is called thyroiditis. Together, those occur in about 15% of patients in a way that need to be addressed with single agent anti-PD-1 therapy, and with the combination regimen that Doug talked about, as many as 50% of patients. And when you see those, you need to give immunosuppressive drugs to tamp down the immune response. So hopefully it just recognizes the tumor and doesn't recognize the host. And that's usually very effective within a few days of starting to reverse those side effects. And then over a 4-week period of time, people would taper off those steroids. And many times they don't need additional therapy. That's an endpoint, and their disease is eliminated. And then the immune-related adverse event is controlled. But sometimes there's not that difference between the recognition of the tumor and the recognition of the immune system that gives you the room to actually safely give the therapy. And in those cases, you need to come up with either a different type of immune therapy or a different type of treatment for the patient. Only about 1% of the immune therapy, immune-related adverse events are serious and not reversible. And those include things like diabetes, myocarditis, inflammation in the lungs, and occasionally some arthritis or neuritis. But most everything else is either completely reversible, or if it involves a thyroid gland or adrenal gland, can be corrected by just taking a hormonal supplement to replace the missing hormones made by those glands.
That's fascinating, Dr. Atkins. So 15% of patients will experience side effect. That's not a big number. So
15 from single agent anti-PD-1, 50% from combination of ipilimumab and anti-PD-1s. And then if you're going to go to cellular therapy and things like that, it's a completely different story. But I'm just focusing on the checkpoint inhibitors now.
Absolutely. Thank you so much for that. I'm going to go over to Suzanne. You've been through many different therapies, and obviously, you and I have chatted, and you've had lots of different side effects and experiences over the years. But can you talk a little bit about kind of how you worked with your oncologist on those and managing them, and kind of what your tips would be maybe to patients out there who are experiencing side effects, how to speak with their doctor, or anything that you've learned over the last 6 years that you found really helpful?
Sure. So yeah, I think I mentioned in the beginning that I've had, or in the last question, that I've had a number of different side effects. And I think what happened with me was I got really, really scared when I got my stage 4 diagnosis and had this tumor taken out of my lung, and had to, take a week off work and have this surgery done, and could hardly get up the stairs because I couldn't breathe. And then suddenly, it was spreading to my liver and fairly quickly also to my brain. And I started the different BRAF inhibitors. And I was very much on this mode of, I'm going to have to do this. I'm going to power through. I'm just going to clench my teeth and do this, because this is now very, very serious and very scary. So I really powered through the different side effects, as I mentioned. Definitely fevers that would somehow happen, a slight fever in the early afternoon, a very heavy high fever overnight. That was kind of daily routine. And these different skin lesions on my legs. And what happened was that one day, as I was taking my medication, I actually passed out at home and kind of collapsed on the floor. Nothing serious happened. I got a bruise on my arm, that was it. But I finally called my oncologist, and she yelled at me in a nice way, saying, this is not the way you need to do this. You need to call us immediately and tell us what's going on. And I have very diligently done that ever since. And that has been, whether it's text messages, emails with photographs of whatever's going on, and getting her response to what I should do, or from her different nurses that are involved in my case. And obviously there's different side effects to different medications. And as I said, mainly it's been these skin lesions. Sometimes it's been all over my body. The fevers has been hard. And some of the immunotherapy has given me, as Dr. Atkins noticed, the colitis. I've had issues with that. And I'm struggling a little bit with that right now. We're taking care of that. So yeah, I think it's for every patient, it's really important to be close to your team. They're almost your extended family. They are some of the most important people in your life as you're going through treatments and all these different side effects. And obviously the time after I went through this T-cell clinical trial was the best time ever, because I wasn't on any kind of medication and I was doing really, really well. And unfortunately, at the same time, tumors started to grow, which was sad that didn't work. Did that answer your questions, or did you have some sub questions?
No, I think that was really helpful. I think, you hit on a really good point about just being really in close communication with your physician to let them know what you're experiencing, because to Dr. Atkins' point earlier, a lot of these side effects are very treatable. So right. there's no need to, sort of power through it if you don't have to, but really to rely on your team and letting them know. So no, that was perfect. Thank you, Suzanne.
Thank you.
So now I'm going to go over to Doug. Doug, you experienced the same thing, and maybe you could talk a little bit about, how you navigated that. I mean, I know your wife, Terry, is very involved as a caregiver and supporting you, but maybe a little bit of tips for some of the patients who are listening and considering talking to their doctor about immunotherapy and wondering, a little bit about what to expect. And I think people want to hear from people.
Yeah. No, sure, Kylie. And, as Dr. Atkins was talking, I was having a lot of deja vu there. Being part of the research trial, I wound up having two side effect occurrences. And you're absolutely right. Having the doctor's phone number and letting him know was probably one of the most important things. We happened to be out of town for the first one. I had migraines, high fever, and I wound up getting on a plane and flying to the hospital to get hospitalized for short term and then return to return to the treatment. So that was while I was still in the trial. When I went on maintenance 3 months later, I had a second side effect, which was a lot more severe. And it wound up being a toxic response to the therapy. And it resulted in autoimmune encephalitis, which wound up being the swelling of my brain. So they stopped the treatment on the spot. I didn't know that because I was hospitalized for a week, and my wife and kids were actually managing my care at that point in time because I was quite a bit out of it. So had a slow recovery. Steroids was a big part of it, and neurological monitoring. And then I wound up having to get into physical therapy to start rebuilding my body because it took a sharp turn. And it was my immune system over-responding very clearly. And it was in hyperdrive. And that was part of the work of the research trial, is to find out where the brakes are on immunotherapy. So I became one at less than 1% of these types of cases and became a case study early on, but it was to the benefit of the drug development. I wound up staying on the research trial for the full 5 years. My last visit was back in January, as a matter of fact. So I continued the scans, the MRIs, the blood work. And as Dr. Atkins said, the treatment kept working even though I wasn't taking any drugs. So it was durable. And, as of next month, and the date sits in our memories, but 11/13/15, 5 years ago, I was no evidence of disease. And that was 3 months after the toxic response. So all has gone well. It was great for the research purposes. It was great for my own personal health. And quite honestly, without an effective team of doctors and caregivers, it wasn't going to happen. So I had very little to do with it. I was just lying there.
Well, we're very happy that it was so effective. Thank you, Doug. So Nadia, I'm going to go over to you because, we've had many conversations about education, right? And educating and empowering caregivers who are caring for patients who are dealing with melanoma. And I think, it's always important to look back and what information do you wish you had at that time that would have helped inform you? And I guess the second part of that question is, how can the MRF as an advocacy organization, what could we do for caregivers going forward? What information do you think would be helpful for caregivers as they're trying to navigate this with the emotional and physical and financial burden that goes along with a cancer diagnosis?
Mm-hmm. How much time do I have? The first thing that came to mind when I was preparing for this was because I have so much I could share and say, but I have to be brief. So I think the first thing is that everybody's different, and it's important to understand that within the context of you're given. You read the insert on what the side effects are. You might have some of them, you might have none of them, you might have completely different ones. It really depends on your age, it depends on your lifestyle, it depends where you're at in your disease. Are you having this as a first-line treatment, or are you having this after many rounds of treatment? It really does make a difference. And are you young and taking care of kids and you have a job, or are you a senior citizen and retired and have different expectations in terms of, what your daily living requirements are, what your quality of life is? All of those things really make a big difference. What treatment you're getting, what dose you're getting. Are you on a new 6-week cycle, or are you still on the 3-week cycle, or, whatever the variations are for the two PD-1 inhibitors, but what other medications are you on? Polypharma is a big problem. So if you have comorbidities, if you're on cardiovascular drugs, if you're on whatever other drugs, we're still, I think, in the beginning of understanding how all those drugs interact. I think there's more knowledge about BRAF/MEK inhibitors that many patients are on and how those react, but still quite behind in terms of warning patients. I had a lot of experience with that. Also where you're being treated, who your providers are. Are you in a big academic center, or are you in a suburb somewhere and are being treated at a local hospital, at a generalist, and your oncologist is a generalist? These things make a huge difference. And sometimes you can feel like you're totally alone. And if you don't know other patients, so you as a caregiver, other caregivers out there are very different. Patients are very different. The doctors, providers are very different. You can have an infusion, the same infusion at the same hospital, but it's different every time depending on what people you come in contact with. People will forget basic things. They'll forget what to do first. So it really is, I mean, I don't want to sound so negative. I'm just trying to say, to recognize that everything is different and it's okay to be confused. So one of the things I recommend is keeping a journal as a caretaker, advocate, and as a patient. My mom actually would forget the symptoms, the side effects that she had, because she would just put it out of mind. She didn't want to remember it. And so when we had to go back into it and do another round of Pembro, or at one point she was on Pembro and injectable in a clinical trial, and then she did the combination at some point. Each time she would totally have forgotten what happened before. And I would try to remind her, and she didn't frankly believe me that it was that bad, that she would be in bed for 10 days, that her arthritis was so bad she couldn't walk. And this was from the medication. She never had arthritis before. And so I encouraged her to just write a journal herself so that she could read in her own words, because what would happen is she would panic when she was having these severe side effects, which weren't acute, emergent, having to go to the emergency room, but really did impact her life and her well-being. She couldn't do the few things that she had left that really mattered to her. So she would panic and think that that was proof that she was getting worse. And I would say, no, you're not getting worse. It's this bad all the time for you. It's fine. And then once she kind of wrapped her head around that, she was like, oh, okay. Yeah, yeah, you're right. I did do that. I did get through that. And so I'm just doing it again. Okay, let's go. And the other thing is to really educate yourself. It's hard as a patient sometimes. I think a lot of patients don't want to educate themselves because it's just too much. It's just way too much. So if you have a good team around you, friends, caretakers, advocates, let them do all the research, ask questions, reach out on message boards, Facebook groups. You can research all kinds of things. Reach out to your peers and never be afraid of getting a second opinion, talking to other doctors. That's really important because people have such different opinions about things. I mean, it's wild how different doctors are and providers. So that's kind of my really quick rundown, and getting good palliative care from the beginning. I mean, it was a long time before it was even suggested to us to get palliative care, which was crazy. Palliative care is not hospice. Palliative care is pain management. Everybody who has cancer should have pain management. I mean, everybody in this world that we're living in should have pain management, I think, let alone if you're a cancer patient. Things like low dose steroid made a huge difference. I mean, really huge difference. Anti-nausea, being able to eat, having good input on nutrition, physical therapy, all these things just make a huge difference. And sometimes it takes so little to make a massive difference in the patient's life.
Absolutely. Thank you.
I hope I answered everything. I hope
you did. You absolutely did.
Point.
You did. And I think that palliative care point is so important. It's about, again, as a patient, and to Suzanne's point as well, like not just powering through, but getting the resources, getting the information, getting the services that are available to patients is so important. And again, as I mentioned at the beginning, the MRF has many resources on our website, specifically the clinical trial finder, if you want to find a clinical trial that you could qualify for, treatment center finder, again, to Nadia's point about getting a second opinion, really finding the resources that are available to you. as well, and the Ask a Nurse program. And there you can see on our website where you can access all of those. We are going to wrap up with one question, and then we're going to go to our message board where we have many people asking questions. So Dr. Atkins, I will let you have the final thought. You know, for those who are watching and, you know, are thinking about immunotherapy, again, it's a big topic out there, especially in the melanoma world. Any thoughts on when, you know, again, we talked about when they should talk about immunotherapy with their physician, but any final thoughts again on as a patient who's considering this therapy?
Sure. I'm going to end on a positive note and say that although the side effects of immunotherapy, and you've heard some of them as well as some of the side effects of targeted therapy, and you probably all know the side effects of chemotherapy, they can be severe. Most of the time they're not. They're largely transient and reversible. And it's always important to keep in mind, particularly for me when I'm seeing a patient with metastatic cancer and they're worried about the side effects, that the most toxic thing in that room when we're having the discussion is the melanoma, because left untreated, that will kill the person. And dying from cancer is not pleasant. And so with immune therapy, we have the potential for preventing that from happening in up to half of the patients with metastatic disease. And that offers oftentimes a short-term course of therapy that is a year or less. And the chance for patients to not only have their disease controlled or to turn their cancer into a chronic disease, but to actually turn cancer into a curable disease. And if patients have their disease controlled and are able to stop therapy, they're not just survivors, they become thrivers, able to once again experience milestone events in their families that they otherwise would not have seen, to go back to work and contribute to their work and to their communities. And like many of the board members of on the Melanoma Research Foundation, give back to society. And it's important to keep in mind that the advances we make through research are not temporary. They're really for the rest of time, and those become the floor from which we build better treatments for tomorrow.
Thank you, Dr. Atkins. Yeah, I think in your opening statement, you even mentioned the cure word.
Yes.
Melanoma, which is huge.
And that is what our goal is when we're treating patients with immunotherapy. It's not, as others have mentioned, to bridge someone between one therapy and another therapy. It's to cure people. And it does do that, but not enough people. And we still have a lot of work to do to raise the bar to a point where the MRF wants it to be, where we're stopping pain and suffering from melanoma for everybody. So there's a few questions in the chat. Do we have time to?
Yeah, we have time for a couple questions. Let's just address the COVID-19 question, because that has popped up. It's on many patients' minds. How has COVID-19 changed the way immunotherapy treatment is being handled with patients, if it has at all?
Sure. At first, we were really worried because some of the side effects from immune therapy are similar to some of the toxicities that we see with COVID-19, particularly the lung inflammation. And a lot of the lethal effects of COVID-19 may be related to the immune system going into hyperdrive, as Doug said, and attacking the body, particularly the lungs. But fortunately, we just haven't seen that when people getting immune therapy have contracted COVID-19, that their disease is any worse than any other patient getting with COVID-19. And therefore, we have really not modified immunotherapy treatments for fear that patients might get COVID-19, except for potentially using the longer interval, larger dose treatments where possible in order to spare patients from driving into the city, from coming into the hospital, even though hospitals are probably the safest place you could practically go inside in this pandemic. Still, a lot of people are worried about that, going to the doctor's office, even getting out of their car in a big city. And so reducing the anxiety associated with that is possible with these longer intervals between treatments. When patients are being checked on, we can do that more by telemedicine now than we used to. But if they need to get therapy, we have to have them come in for the IV infusions.
Thank you. We always have to ask the COVID question. I think it's on everybody's mind. So thank you for that.
And it's an important thing that the MRF is looking at as well, and
Mhm.
how it's affected melanoma research and melanoma patient care in general.
Absolutely. Absolutely. Thank you for that. We're going to wrap up with one final question. So first of all, a big thank you to Nadia from one of our viewers saying, thank you so much for the journal idea for care partners. I think that's a really great, wonderful tip. And this question is for you, Nadia. So as a care partner, how involved did you want to be in the treatment process with your mom? Can you talk a little bit about how you felt you wanted to be connected in that way?
I mean, 1,000%. I felt my mom was quite shy. And so she thought that whatever she was told she had to do. And so I really had to step up and ask the uncomfortable questions. You know, I would ask, she would feel really bad at home. We would go into the doctors and then she would act as though she feels fine. You know, I was the bad cop, she was the good cop. And I would say, you have to explain in your own words how you're feeling. You have to really, you know, confess how you're feeling. And she would still try to like get out of it during appointments. So I mean, I was dragging her to the city from her home in Pennsylvania. I was driving her when she was throwing up in the car on the way to the hospital, like all of those kinds of things. I had to be involved and I really wanted to. And I really found a community with the MRF. I mean, I cannot say how, what an impact this was for me to find you guys and to participate in events, to find the message board and to be able to connect with other patients and other caregivers. It was just, you guys are just an unbelievable resource for our community. And I thank you so much.
Well, thank you. And thank you all for really sharing your experiences and your time. You're really helping a much wider melanoma community today. And this is such an incredibly important topic, and certainly one that's top of mind for many recently diagnosed melanoma patients and those who are going through their journeys as well. And to Dr. Atkins for your wonderful insights into the future of where we're going. I think that brings a lot of hope to many people. So again, a big thank you to you as well. I will just be wrapping up now. I just, again, want to thank all of our panelists. And for those of you, if we didn't get to your question, we will absolutely answer it offline on our page. We have our last session coming up next Wednesday, October 7th at 4 p.m. Eastern. We hope you're going to be tuning in. We're going to be talking about the Society for Immunotherapy of Cancer. It's the SITC conference. It's a medical conference featuring Dr. Glenn Merlino, who's at the NIH. He is the counterpart to Dr. Atkins on our scientific advisory committee, and that's going to be moderated by Kelly Malloy at OncoSec. So we hope you will tune in next week again for a wonderful session, and we would like to again thank OncoSec for their tremendous support and our wonderful panel this afternoon. So thank you again, and we will see you next Wednesday. Take care.